hemiplegia.
Slideshow. Forward it. Respected chairpersons, dear sirs, and my dear colleague, a warm welcome to today's topic presentations. So myself, Dr. Remya, I'm coming from Rajagiri Hospital. I worked there for past 8.5 years. Dr. Nitin Menon was there as my senior. I am a pass out from CMC Vellore. After the MBBS from Kottayam Medical College, I did my MD from CMC Vellore. And from there, after that, I am working at Rajagiri Hospital. So coming to the topic, shoulder in hemiplegia. So this stroke as such, in the Rajagiri aspect, there is an interventional neurology fellowship there. So we get enough number of cases, n number of consultations each day with the stroke, and infarct strokes and bleed strokes will be there. So right from the ICU phase, we start seeing patients. So we get enough number of consultations every day in the acute, subacute, and chronic phase, and we also are associated to a CBR project called Peace Valley. That is at Kodamangalam. That is a institution run by Thanal. So from to there, we give the referral. So we have to make a rehab plan for the patients. At that time, we plan the rehab program. So that way also we get enough number of patients in the subacute and chronic phase. So this is an entity which we come across in our daily practice, and it is a challenge. So the epidemiology, according to studies, it says that 85% with the spasticity is associated with the, those cases which is having spasticity. 85% of the patients will be having this hemiplegic shoulder pain, and in the flaccid stage itself, it will start at least 18% of the patients will be having, and overall, the pain incidence, hemiplegic shoulder pain incidence in stroke patients is almost 84% according to studies. And association of subluxation, that is the most important finding associated with this HSP, that is almost 81% association is described in studies. And association of reflex sympathetic dystrophy as the cause for this hemiplegic shoulder pain is described, and 27% spasticity can be seen associated, and in flaccid condition also, that is in the early stages, also this RSD is associated. And the most challenging factor in the stroke is anatomy and the distortion of the anatomy. That is resulting in this HSP. So well approximated glenohumeral joint, elaborate discussion of anatomy we heard yesterday. The glenoid fossa angle, which is keeping it up in the forward and upward position. The scapular alignment with the vertebral column. All these important anatomical and biomechanical factors are getting affected in the hemiplegic shoulder. So the effects are joint stabilization is disrupted. This scapular alignment is disrupted. Vertebral column in the upright alignment is disrupted, mainly because of the muscle weakness. So the joint stabilization, basically the supraspinatus, deltoid, latissimus, all these muscles are getting weak. The supports are getting weak. The scapular alignment is getting distorted. And the vertebral column alignment in relation with the scapula is also getting distorted. So coming to the pathophysiology, there, the evolvement of this hemiplegic shoulder pain is greatly associated with the stages of evolvement in the stroke. That the muscle, when it is going into the flaccid stage, from there to the spastic stage and the synergic patterns, the hemiplegic shoulder pain also will be in its own evolution. So the flaccid stage, it will be areflexia, the muscle support of the humeral head in the glenoid fossa will be lost, the downward and outward subluxation of the humeral head is happening. So this results in two things. The muscle support is lost and the joint capsule is getting unduly stretched. So the muscle supports which are lost, we know that is a trapezius, rhomboids, serratus anterior, flaccidity is bringing depression, protraction and downward rotation of the scapula, resulting in the angular changes of the glenoid fossa, resulting in subluxation. The righting reflex is also getting eliminated, resulting in lateral spinal flexion to the hemiparetic side. So that distorts the scapulothoracic relationship. So this is the basic reason, that is the loss of the muscle support, which is resulting, contributing one factor. And the other factor is this thing, that is a joint capsule unduly getting stretched. So the outer stratum fibrosum is there, inner stratum synovium is there. Synovium is highly vascular, but the fibrosum layer is highly innervated. So that is the area, that brown, okay, so that brown area where the stratum fibrosum is getting unduly stretched. So this capsular stretch is bringing, in the flaccid shoulder, is bringing irreversible damage to the capsule and to the shoulder joint, which is triggering the most important thing, that is the CRPS. So what has happened, that is then the flaccid stage. So what is happening in the spastic stage? In the spastic stage, the premotor and the neocortex, which was in the control, is lost. That is controlling, modifying, refining, coordinating the proper impulses that is firing to the muscles. That is getting distorted. So what is happening? The upper extremity flexor patterns and lower extremity extensor pattern is developing. And so the cortical control interrupted, resulting in synergy pattern, that is a spasticity, which is again paving way to the hemiplegic shoulder pain. So in the synergy state, we can see this pattern, which is very common in our clinics. So the scapula will be downward, the shoulder will be adducted and internally rotated, elbow will be flexed, wrist will be flexed, fingers will be flexed, and the patient will be coming like this. So the etiology of the post-stroke, so these are the normal the routine pathophysiology, and what is bringing this post-stroke shoulder pain is, the most important thing is glenohumeral subluxation itself. This will start on onset from 3rd week of the post-stroke itself. The weight of the flaccid arm is the most important contributing factor. Improper positioning, improper transfer techniques, lack of support in the upright position, pulling of the hemiplegic arm when transferring, especially the ignorance of the caretakers, that is especially our nurses and our caretakers. So this is the most important reason which is resulting in this complex regional pain syndrome, that is the reflex sympathetic dystrophy. That is one reason contributing to HSP. And the second thing is spasticity, which we already explained, the reason of spasticity. So the spasticity pain, spastic pain, spasms, that pain is the second contributing factor. So third one is complex regional pain syndrome is contributing in HSP. How? So it is otherwise called shoulder hand syndrome, shoulder hand. So the reflex sympathetic dystrophy, it is otherwise called causalgia. So sympathetically maintained pain, it's otherwise called pseudic atrophy. So this CRPS type 1 and 2 is there. Type 1 is mostly associated. So it is due to the noxious stimulus that are not limited to the distribution of a single peripheral nerve. It is a complex multi-nerve is affected. Causalgia is usually a single peripheral nerve. So this metacarpophalangeal joint area tenderness, that is the best diagnostic indicator in this CRPS1, that is the HSP associated CRPS. So the sensitivity is almost 85 and specificity is almost 100%. This MCP joint tenderness associated with CRPS. And another one is adhesive capsulitis. Yesterday also we heard in elaborate sessions regarding adhesive capsulitis, what will be the presentation, chronic irritation or injury or inflammation or lack of movement eventually resulting in adhesions. So what is happening? The ROM is restricted, ER and abduction is restricted. So in a study with arthrography in 30 patients with the hemiplegic shoulder pain, they found this adhesive capsulitis associated with HSP in almost 77% of the patients. Next thing is brachial plexus traction neuropathy. Because of the undue pulling of the patient, the caretakers will be just pulling the hemiplegic arm over the arm or forearm just like that. So, and it is unsupported. The position is wrong. So, this traction neuropathy is bringing improper handling at the home by the caregivers, proper transfer, improper transferring. So these are the brachial plexus traction neuropathy is another thing that is straight away contributing to HSP. So proper transfer techniques should be there. Some association, not much common as traumatic brain injury or spinal cord injury, but HO is also an association which is leading to HSP. Another thing is neglect. The patient is just not considering that side. I don't have that side. So sensory issues more often. So they are not aware if they are getting a pull on that side also, they are not aware about that. So because of the sensory issue. So traction injuries are more common because of this neglect of the patient as such. And another association is thalamic syndrome. So that is a central reason. All these were the local reasons, but another thing is a central reason. Central reason is thalamic syndrome. So central post-stroke pain, otherwise called analgesia dolorosa, Dejerine-Rossi syndrome, usually occurs in less than 5%. It is less in number, but those patients with thalamic stroke, this association is very much. So pins and needle sensation, the sharp shooting, stabbing, gnawing, dull, achy pain. So that is thalamic stroke syndrome. And there will be hyperpathia. Even with a feather touch, even with the finger touch, the patient will be just exhausted with excruciating pain associated with the thalamic syndrome also associated. Then soft tissue injury or trauma, which already we discussed, the improper positioning, transfer, stretching, all those things. The signs and symptoms. So we all know that is atrophy, asymmetry will be there, swelling, edema, pain, tenderness, ROM will be restricted, coordination will be affected, reflexes will be problematic. So all this clinical examination part we are aware there will be anatomic variation and there will be sulcus sign. We can even place our index finger just in between the humeral head and acromion. So the neurological examination should not be for the pain per se. The cognition should be assessed, muscle power should be assessed, sensory evaluation should be there, reflexes, coordination, cranial nerves, then visual fields. All these should be combined and examined in a patient presenting with hemiplegic shoulder pain, because clearing all these things only is bringing comprehensive results in the patient. So evaluate for the neglect, evaluate for apraxia, and the film should be recorded how much functional dependency is there for the patient because of this problem. And differential diagnosis can be chronic pain syndrome, fibromyalgia, even median neuropathy, associated other arthritic, inflammatory arthritis, neuropathies, thoracic outlet syndrome. So all these should be kept in mind while we are examining a patient with HSP. So the workup will be blood and scans and radiological investigations. I am not going into the details of this. Few words regarding the prevention, because that is the most important thing which is going to benefit the patient. The prevention, that is always better than the cure. So most important reason for the initiation of the hemiplegic shoulder pain is unsupported shoulder. Unsupported shoulder. So the undue positioning, traction, all these should be taken care while the patient is moved from one position to another, from bed to wheelchair, from wheelchair to car, from commode to wheelchair. So all these transfers, what is happening with the shoulder, how the caregivers are pulling it just like that. So the three main keys of prevention is adequate support. Always tell the patient you should be in a chair where there is arm support is there. If it is not there, keep just 2 pillows, or right arm board should be there. So educate the patient regarding the anticipatory pain that is going to come in him, and educate him like that. So adequate positioning and early gentle mobilization. So whenever I get a consult and go into the room of the patient in the ICU or in the bed room, the patient will be lying like this. This is a last week patient's picture. So this is a father. He is just lying like that with the unsupported hemiplegic upper limb, not even a pillow below the hemiplegic upper limb. So the capsule is getting continually stretched 24 hours. And it was, now this is a post-treatment 2 or 3 days later only, after crepe bandaging and so many measures. Otherwise, much more swelling through the entire limb was there. So this is the condition, unawareness regarding the support that should be given to a hemiplegic upper limb. And this is so in the lying down position, the upper limb should be, shoulder should be in abduction. So with a pillow support, shoulder should be in abduction. And when he is lying on the hemiplegic side, the arm should be supinated, the finger should be straight. So always take care when we go into the patient's room that the patient is on the pillow support. So emphasis on that. This is a recent, last few days back, one patient is coming. We can see so many things in this picture, read so many things in this picture. The sling is there for the patient. Somebody has described sling for the patient. Patient is obeying that also. But what this man is doing, this is untied from the neck area. It is over through the neck. There is no neck support. There is a armrest for that wheelchair. But he is not even keeping the arm over there. And the patient is presented with a severe HSP. So this is the condition because of the lack of awareness. The prevention is there, aspects are there with the patient, but he is not using. He is just wearing it like a blanket. So while sitting, educate the patient and nurses that this should be the position. The arm should be supported while he is in the sitting over the chair. There should be the supporting position. Arm should be abducted. Elbow should be extended. The finger should be straight. So another challenge is, this is thing when it is in the room or over the chair. What will happen when a hemiplegic patient is walking? How will the arm will be supported? We need a proper orthotic to support the arm. So what are the main challenges? The main challenges is weight of the limb itself. Who will hold it? The shoulder itself is weak. Then this entire hand is weak. So whether it should be connected to the neck, then the very next week, the patient will come with the cervical spondylotic pain or neck pain. How it will be connected to the other. Somebody should hold the hand, and that the patient should himself hold the hand. Then where the weight of the limb will be connected. That is the main challenge for designing this orthotic. How can we transmit the weight to the opposite limb? So neck is out of question. Then it should be transmitted to the opposite limb. How effectively the weight of the one limb will be transmitted to the other limb. So that is the challenge. So how to keep the joint in position? That is another challenge. Humeral head in glenoid fossa, how we will keep it. How we will bring abduction and external rotation. So design a support. We have seen n number of support in our practices. We can say enough drawbacks to each of the supporting designs. And another question is, it should not interfere with the patient function, that support sling. And it should be relatively easy to don and off. Otherwise, the patient will not wear. It should not create any new problems, like edema in the dependent hand. It should not bring any synergy patterns. It should not affect the cervical spine. It should bring the scapulohumeral alignment. So bringing all these challenges into consideration, how we will design a simple orthotic sling to prevent subluxation for the patient. Immobilization is easy, but how we will keep it supported? So that is the question. Available ones don't really meet the real needs. So we were in thought like how to build a simple orthotic device. Challenges in designing complex, because of the complex anatomy, complex anatomical shape. If it is for the LS corset, it is very easy, just a strap like that. If it is for the solid AFO, the shape is very easy to design. But what for the shoulder joint, which is a very complex shape, complex biomechanics, so how we will design? So the weight transmission to the opposite limb, abduction, external rotation. This is mandatory, should be mandatorily getting with our orthotics. So we have just came across a solution, may not be fully, completely satisfying all these needs, but to our practice, it has shown that good benefit, and whoever is really compliant, really wearing this orthotic has never turned up with further subluxation. So I will just show with few minutes, madam, this product. Actually, this is a two-piece thing. This is the arm strap, and this will be the other opposite limb strap. Two things are Velcro only. This model was actually available in CMC, and we might have also seen this, but we have just added an abduction cushion. This is a foam cushion which is covered with a pure cotton stockinette. So this is sweat, it is sweat resistant. And this is the axillary part. Ideally, it is a small wrong is there. It should be just coming to the axillary area to keep correctly holding it in the axilla to keep it abducted and supported. And the entire, in the screen, we will be seeing that the opposite, this thing will be connected through an O-ring. So through this O-ring mechanics, the entire weight of the arm is getting transmitted to the opposite ring. Initially, we should wear this. After keeping the patient in position, we have to readjust these 4 Velcro straps, getting proper alignment of the body and the shoulder. So it is to be taught to the patients also how to don and doff. So this is a really helping sling, which is meeting the needs to weight transmission to the opposite limb and also bringing abduction and external rotation. So this is the thing that we use in our hospital. So management of, so rushing through the next of the slides, that management of HSP, that subluxation should be managed, spasticity, CRPS, adhesive capsulitis, this brachial plexus traction, neglect-related pain with caloric stimulation and so many other measures. Thalamic syndrome should be managed with adequate measures. So all these etiological things we should find and we should manage. And the treatment options, we know that physiotherapy and the pharmacological measures, not going into the details of physio, early ROM, stretches, constraint-induced, shoulder strapping, sensory motor integration, robotic assisted, then biofeedback, motor relearning, just rushing through the names like electrotherapeutic measures, NMES. All these measures will help in preventing and reducing the onset HSP. The interventions, we know that intra-articular steroids we usually will be practicing. Specific things mentioned for HSP is subscapularis motor nerve point block. So that internal rotation synergy is locked, and this is bringing benefit to the patient. Immediate improvement in external rotation, abduction, and flexion reduction in pain is noted with this subscapularis motor point. Another thing is musculocutaneous nerve neurolysis. This is mainly for elbow flexor spasticity. It is also described.
Dr. Remya Mathew, you may finish quickly.
Yes, sir. Just
I hope 1 or 2 minutes will be more.
Yes, sir.
Enough.
Yeah. Surgical intervention, that is in the extreme cases, is also recent advances. PDRN is described. PDRN, that is polydeoxy ribonucleic acid, that is a new agent which is acts by the stimulation of adenosine A2 receptor. This is decreasing the local production of TNF alpha interleukin. So this is the USG guided PDRN injection for HSP. New thing that is described, hyaluronic acid, which helps in enriching the shoulder joint, that is also described. Robotics for CPM, ROM for the shoulder joint is described. Radio frequency, continuous, rather than continuous radio frequency, pulsed radio frequency, especially concentrating on the sensory nerves, inhibition of type C fibers, and enhancing the activity of serotonergic and noradrenergic pain inhibitory pathways. This is described, so and this is getting practiced in several hospitals also. This is the PRF of suprascapular nerve, which is helping in HSP. Regenerative medicine approaches, PRP, we are going to hear about in detail. And another thing is perineural injection therapy. So here it is another regenerative approach. So it is the constrictive subcutaneous nerves are given injection. So it is based on something called Hilton's law. There the nerves supplying the muscles innervate the joint and the overlying skin. So this cutaneous nerve, when it is in ischemia,
Dr.
it is bringing
Remya,
pain.
I hope that you have exceeded time.
I am
too
finishing,
much.
sir.
You will get again opportunity at the end of the session.
Okay, sir.
Many persons may have so many queries.
Okay, sir. So I am just finishing. We can hear about this and get more clarity from Dr. Ravishankaran also, because he is a man who is really into this perineural therapy for HSP. And anatomical locations, it is described in the references like this. So thank you all for patient listening in the early morning. Thank you so much. In the way of crows, actually it is the described pain. The shoulder pain was the most excruciating pain that Jesus has suffered because of the heavy vascularity and neurological support for the shoulder joint. So we must do something about it. Thank you.
Okay, till this time the timing was followed very correctly, but for Dr. Remya Mathew, it's that. Now, anyway, hemiplegia or cerebral apoplexy, this is called Pachakadam. Akadam is a real akadam to the side involved, especially the shoulder. And if left untreated from day itself, as she has correctly pointed out, starting from the first 24 hours, it is complicated to have the hemiplegic shoulder, HSP.